Good evening, everyone, and welcome to today's session. There are so many things. This year's NEET PG has become the most delayed love affair. It is not ending up in that marriage. But the students who are in the final year, MBBS, have entered into internship, and now they are ready for 2022 NEET PG preparation. So almost 70,000 new students have joined the game of competition, while their seniors are still uncertain about the entrance exam date. So whatever it is, our session for the 2022 has started. The idea is every day 6 to 7 p.m. all 365 days we have 6 to 7 class where you will have a quiz followed by discussion. So around 30 MCQs, mainly to stimulate you every day. So there is a schedule for this daily evening 6 to 7 p.m. session. Also, every NEET PG, in the top 5,000 ranks, we are catching up with around 150 toppers of the most recent NEET PG. They are ready to become your mentors. So a lot of face-to-face coaching classes are now obsolete. Going and sitting in crowded classrooms is out of question. The second thing is there any chance of all the apps where you have the national faculty, book writers, authors as teachers, but they will not have the kind of connection that you need. Incus is the only place where the NEET PG toppers of yesterday become the teachers today, right? So that is going to be the future. Mahima is saying, sir, please discuss dental related questions also in medical subjects. Definitely, we are getting some of the dental teachers a separate class broadcasted. So don't worry, we will also start doing the live online classes for the MDS entrance coaching also shortly. So let us make the great beginning, doctor. Don't forget, every day 6 p.m. to 7:30 p.m. Tsunami ho, earthquake ho, kuch bhi ho. You have a free YouTube live broadcast every day. Only thing is, we will remove the video after the class is over and make it private and make it available in the Incus app. So please download the Incus app. Also, we are getting a lot of toppers. Regularly, they will be conducting a lot of free learning sessions. And be part of our WhatsApp group so that the NEET PG toppers can mentor you. You can get a direct one-to-one connection with the NEET PG, mostly recent NEET PG toppers on the strategy for the preparation for the entrance exam. So let's make the great beginning, doctor. Yes. What is the route of administration that has the highest bioavailability? The moment you inject a drug into the vein, then obviously intravascular has 100% bioavailability is what you need to basically remember. Neostigmine versus pilocarpine. What is the difference? So, you know, there are muscarinic receptors, nicotinic receptors, and nicotinic are there at the neuromuscular junctions. And neostigmine fundamentally is the one which can be able to block the nicotinic receptors, and that is how it leads to skeletal muscle paralysis is what I want to underscore to all of you. Now, competitive antagonist, how does it act on the dose response curve? So you should remember, how does a dose response curve basically look like? Avani, Parmar, and many more who are all online, I'm very happy to see that you need to actively participate. That's the reason, before we start the session, we have a quiz. And there will be one link. Please go to that link on your mobile phone or whatever, and you can start dynamically answering the questions, and your results will keep coming on the screen, so that you have the competitive spirit of preparing for the competition. After that, I'll come down and then we will have a discussion. And not only me, there are going to be almost 50 national faculty who are going to teach you in the 6 to 7 session. So that is the reason, get yourself tuned to the YouTube channel /online MBBS, and then you get a lot of content of live online interactive preparation every day on the Incus. So doctor, there will be a parallel right shift. So what do you need to know about the dose response curve basically? The dose on the x-axis, and you have the measured effect, like the blood pressure, how much it came down, or how much is the heart rate increased. This is called response. So this measured response on y and the dose on the x-axis. So typically this is the dose response curve, and the maximal efficacy, that is how much of response it is able to achieve, is called maximal efficacy. If you have used antipyretic X and antipyretic Y, which one could be able to bring down the temperature maximum? That is efficacy. And to achieve a given effect, how much dose you require? If you require less dose to get the same effect, if you are able to get it at a lesser dose, then typically that is called higher potent drug, as all of you know very well. So if you look, X and Z have same efficacy. X and Y have same potency, right? Sorry, X and Y, if you take X and Y, if you happen to take, the X is achieving certain response and Y is achieving lesser response. So at the same maximum response achieved. That's the reason efficacy of Y is lesser than X. Efficacy of X is same as Z. But in order to achieve the same level of efficacy, the dose of X required was lesser than the Z. That is the reason X is more potent compared to that of the Z, because even at a lesser dose only, it is able to achieve the higher amount of efficacy. So, if you look at the competitive versus non-competitive antagonist, there is a right shift. There is a right shift with the competitive antagonist is what you need to basically remember. A 45-year-old man, recently a recipient of the heart transplant, which drug cannot lead to tachycardia. Actually, all these are sympathomimetic. But what is the difference between one and the other, doctor? Amphetamine is an indirect acting sympathomimetic agent. Indirect acting sympathomimetic. Whereas the remaining three drugs, they're all directly acting sympathomimetics. What do you mean by directly acting sympathomimetics? Either dobutamine, epinephrine, or isoprene, they have the same action like catecholamine. So they simply go and act on the receptors, beta 1, beta 2, alpha 1, whatever. They will directly go and act on it. Because these drugs directly have that sympathomimetic effect. Whereas amphetamine will indirectly go and cause increased release of catecholamine. And that increased release of catecholamine, that catecholamine that got released, then will go and act on the receptor. That is the reason amphetamine is called indirect acting sympathomimetic. So that is the reason if you take an indirect acting sympathomimetic, then the entire nerve should be intact. Not just the receptor, nerve should be intact. A transplanted heart has only receptors, not that relevant nerves. Nerves are that of the host. So only receptors it has. So that's the reason on a transplanted heart, what will add? Only the direct sympathomimetic, but not indirectly acting sympathomimetic is what I want to underscore to all of you. So this is very important for you to remember, doctor. Don't forget. What is the classification of this sympathomimetics? You have direct acting agonists like epinephrine, norepinephrine. Indirect acting, which will enhance the release of the norepinephrine from the vesicles. Like amphetamine, cocaine. Whereas both the direct and also indirect is there for ephedrine and pseudoephedrine is what I want to underscore to all of you. So don't forget this favorite classification of the examiner. Postsynaptic M2 receptor. What is the effect of it? Muscarinic receptor. Basically, it will cause a decrease in the cyclic AMP formation is what you have to remember. Then, ganglionic blockers. How do they act? So, ganglionic blockers, They can block all the autonomic reflexes. So they block the nicotinic receptors at the autonomic ganglia, adrenal medulla. So what are the examples of ganglionic blockers, doctor? Hexamethonium, mecamylamine, they are the ganglionic blockers. And they don't have any effect on nicotinic receptors. They don't have any effect on nicotinic receptors. Is what you have to basically remember. If you look at the ganglionic blockers, you have parasympathomimetic and sympatho. They act on sympathetic or parasympathetic. So they can block parasympathetic ganglia. That's the reason there will be constipation, urinary retention, tachycardia, cycloplegia, xerostomia, everything. Similarly, they also can block sympathetic ganglia. So vasoconstriction is blocked. That's the reason there is a development of vasodilatation is what you need to basically remember. So nicotine in large doses is a depolarizing ganglionic blocker, whereas trimetaphan, hexamethonium is a competitive type of ganglionic blockers. Once more, within the ganglionic blockers, you have a subclassification which you need to remember. So once more, doctor, on the Incus app, you have 2000 HD videos, 2000 PowerPoints discussing 953 high-yield topics on the Incus app. Today only download it. Still, every day evening 6 p.m. to 7:30 p.m. Monday to Saturday, you have a live class on the YouTube. So don't forget to attend this live class so that will stimulate you to go back to the Incus app and do the revision. If you ingest mushrooms containing pilocarpine, so what does it lead to? It leads to the development of diarrhea, is what you need to remember. So pilocarpine is present in mushrooms, and activation of the muscarinic receptors of the GI tract lead to the development of diarrhea. Now, there are two different treatments. The size of the pupils of a patient's eye without treatment and with two different treatments is being shown to you. So what is your conclusion? So that shows that there is a radial muscle denervation. Why did we conclude like that? Whenever you are giving phenylephrine, which is a direct acting sympathomimetic, it is responding and that is leading to the development of a pupillary dilation. Whereas amphetamine, which is indirectly acting, is not able to do that. Why does it happen? Because there is a denervation. Because amphetamine is an indirectly acting sympathomimetic, just like whatever that we have discussed in the earlier question, right? Same logic. Now, there is a drug U with phenoxybenzamine, which is both alpha and beta blocker. You got a response like this. With only beta blocker, propranolol, you got a response like this. And with mecamylamine, you got a response like this. So then what is this U which you are using? So the effect of the drug U, if you look, with propranolol it is not affected. Then it is only affected if you are giving an alpha blocker like phenoxybenzamine. That means it should be an alpha agonistic drug. So indirectly examiner is asking which is an alpha agonistic. Once more, you should remember. In alpha, you have alpha 1, alpha 2. So, typically alpha 2 is presynaptic, alpha 1 is postsynaptic, which is present on the vessels. Postsynaptic, present on the vessels. So, whenever this postsynaptic alpha receptor is stimulated, postsynaptic alpha receptor is stimulated, it leads to vasoconstriction, is what you need to remember. Barabar? So now, how did you conclude it is phenylephrine? Because if you give beta blocker, it is not getting affected. If you give alpha blocker, it is getting affected. That means that must be an alpha agonistic agent. Out of this, phenylephrine is only alpha agonistic agent, is what you need to basically remember. 400 milligram per hour. Clearance is 50 liters per hour. It's a very, very simple, easy question. Now, what is the plasma level at steady state? So you should remember, the rate of elimination at steady state is, you should remember, rate of elimination of steady state is clearance into steady state concentration. Barabar? So that is the reason the rate of administration should also be clearance into expected steady state plasma concentration of the drug. So, considering an infusion rate of 400 milligram per hour and a clearance of 50 liters per hour, the steady state concentration will be 400 by 50, which is equal to 8 milligram per hour, is what you need to basically understand. 100 is between 50 to 25 to 12.5. So that means it is what type of elimination candidates? First order candidates. So the drugs that follow the first order elimination, they have a constant elimination half-life, is what you need to remember. Similarly, the clearance and the volume of the distribution, they do not routinely change with the dose. In case of the first order candidates, is what you need to basically remember. Now, if a drug is distributed into total body water, what dose do you need to obtain an initial plasma level of 5 milligram per liter in a patient who is weighing 70 kilograms? So first of all, you should know, in a 70 kilogram individual, how much is the total body water, doctor? You have 60% is the total body water. That means 70 kg आदमी में 70 to 60% is 42 liters will be the total body water into 5 milligram per liter. 5 milligram per liter is what you wanted to basically achieve plasma level. So that means 42 liters into 5 milligram per liter is equal to 220 milligram, 210 milligram should be your loading dose, is what you should remember. A patient was given 200 milligrams, 100 milligram was eliminated during the first 2 hours. And if the drug has a first order kinetics, how much drug will remain 6 hours after? 6 hours में कितना half lives है? 3 half lives है. पहला हाफ लाइफ में बन गया 200 बन गया, सेकंड हाफ लाइफ में 150 बन गया, बराबर 50, थर्ड हाफ लाइफ में 50 बन गया 25. That means 25 milligrams will remain, is what you need to remember. Carvedilol is an effective antihypertensive like propranolol. But what is the difference between carvedilol and propranolol? Carvedilol has an intrinsic sympathomimetic activity, one of the favorite questions of the examiner. Thermoregulatory sweat glands in the body. What is the pathway? Typically, they utilize cholinergic nerves and muscarinic receptors. Thermoregulatory sweat glands in the body is what you need to remember. So, thermoregulatory sweat glands are only innervated by sympathetic nervous system. Generally, sympathetic postganglionic nerves release catecholamines. But exception क्या है? Sympathetic nervous system innervating the thermoregulatory sweat glands, instead of catecholamines, it releases acetylcholine. That is a point you need to remember. Everywhere postganglionic sympathetic means catecholamines, but in the thermoregulatory sweat glands, the exception is the acetylcholine. When there is an activation of the muscarinic receptor in the bronchial smooth muscle, what is it associated with? There is an increased inositol triphosphate and diacylglycerol. So always remember, the muscarinic receptors, what do? They lead to bronchoconstriction. And your ipratropium bromide, which is like atropine, ipratropium bromide, what does it do? It leads to bronchodilation by antagonizing the muscarinic receptors. So, when acetylcholine comes and binds with this muscarinic receptors, how does it lead to the smooth muscle contraction? So, in that, phosphoinositol diphosphate become broken down into inositol triphosphate and diacylglycerol. Inositol triphosphate acts on the receptor that releases the calcium, and that leads to the smooth muscle contraction of the bronchi, leading to the development of the bronchoconstriction, is what you have to emphatically remember. So, doctor, once more, I'm telling you, all of you, 2022 का NEET PG preparation batch of Incus has already started. Please subscribe yourself. Every day 6 p.m. to 7:30 p.m. we have a live online interactive class, Monday to Saturday on the YouTube. After the session is over, we remove this video. Then on every Sunday, there is a 10 to 1 p.m. grand test. And 2 to 5 p.m., 4 p.m., there is a discussion. Don't miss that. So totally, starting from April 25th to January 31st of 2022. So totally there are about 36, around 40 weeks later, 40 weeks of time we have. In this 40 weeks, we take 240 classes every day, Monday to Saturday, 1.5 hours. But this is mainly to stimulate you to go back to the onlinembbs.com and Incus video library. So every day take a quiz, 30 question quiz, and get yourself ready and activated. Not only me, lot of teachers are going to join into this teaching parade, right? So, and also the NEET PG toppers of the recent NEET PG entrants are going to be part of our WhatsApp group. They constantly mentor you. You can ask any doubts about the strategy of preparation, etc., because they belong to your age group, your generation. So that is the reason they recently cracked the top rank. That is the reason always they are the best teachers, in my opinion. If you increase the concentration of the norepinephrine in adrenergic synapses, what does it lead to? It leads to activation of presynaptic inhibitory G-coupled receptors. So, in the sympathetic nerve endings, presynaptic alpha 2 receptors are coupled to inhibitory G proteins. These proteins act like an auto-regulatory and they inhibit further neurotransmitter release and decrease the synthesis of norepinephrine. Now, what is this drug X, which is showing its effect in reference to acetylcholine? It is hexamethonium because it is decreasing the blood pressure. It is decreasing the blood pressure and also decreasing the heart rate. And generally, any decrease in the heart rate is overcome by immediate sympathetic reflex. And drug X is abolishing that reflex tachycardia. And that is only possible if it is a ganglionic blocker like hexamethonium is what you need to basically remember. So that is the reason, because of the inhibition of reflex tachycardia associated with the fall of the blood pressure, we conclude that it is a ganglionic blocker and that would be hexamethonium. Now what is this drug R? You look effect of R with phenoxybenzamine, propranolol, and mecamylamine. This is how examiner will give. Phenoxybenzamine is an important alpha blocker. Propranolol is a prototype of beta blocker. Accordingly, you should conclude. So, the effect of the drug R is changed by treatment of either alpha blocker or even beta blocker. So the drug R must have an activity at both the receptors. So if you look at those various catecholamines, only norepinephrine has an agonistic activity at both the alpha and also the beta receptors. So that is the reason it is the drug is norepinephrine is what you need to remember. How does botulinum toxin function? It prevents the release of the acetylcholine is what you need to remember. Botulinum toxin. Once more, how does tetanus toxin work? Botulinum toxin, strychnine poisoning, everything you have to be 100% sure when you go to the tomorrow's NEET PG Topper. This is a very interesting question. 500 milligram dose has a therapeutic efficacy. That means whenever you give the drug, there is certain minimum inhibitory concentration. And this drug is above that minimum inhibitory concentration for a period of 6 hours. And it has a half-life of 8 hours. So if you double this dose from 500 to 1 gram, how long it will be effective? So the drug has a therapeutic efficacy of 6 hours. It has no direct relation to its half-life. That means drug is above its minimal effective concentration for 6 hours. If you double the dose to 1 gram, the drug will remain above the minimum for a longer period. And because the elimination half-life is 8 hours, 500 mg will remain in the body 8 hours after the dose of 1 gram. So that is the reason total duration of effectiveness will be 8 plus 6. That will be 14 hours is what you need to understand. What is that phase 2 drug metabolism reaction where you find genetic polymorphism? Acetylation typically has genetic polymorphism. So typically patients who are taking ethylene, taking hydralazine, procainamide or isoniazid, they're all the classical drugs that show genetic polymorphism for acetylation. slow acetylators, fast acetylators. So IV drugs are all 100% bioavailable, and most of the drugs that gain entry into the cells, they gain entry through passive diffusion. अगर एक दवा सेल के अंदर जाना बोले तो रिश्वत देने का जरूरत नहीं है. Passively only it will diffuse. It follows first order kinetics. Most of the drugs. So few drugs require active transport, like penicillins. You require active tubular secretion. Similarly, some drugs penetrate membrane via aqueous pores, like ethanol. That is what you need to appreciate. Now, the data which is presented in this figure, what do you see? Drug A, drug B, both of them are achieving the same level. That means they have an equal efficacy. Equal efficacy. That's what you need to remember. Drug B is more potent than drug C. Because if you take any given level of effect, that effect is achieved. For example, let me show you. If you look drug C, this effect, it is achieved by drug B at a smaller concentration than the drug C. Drug C required a higher dose to reach this level, and drug B is able to achieve it at much earlier level. So B is more potent than the drug C. Drug C is a partial agonist because it has less efficacy than the full agonist. That's what you need to understand. Which drug which of these will result from activation of beta-2 receptor? Beta-2 receptors lead to smooth muscle relaxation on the bronchi and on the blood vessels. Blood vessels, smooth muscle relaxation lead to vasodilatation. Vasodilatation lead to decrease in blood pressure. Bas, khatam. Now, this is interesting. Once more, phenoxypyrazine, methyl, mecamylamine, and propranolol. This is Mr. Propranolol is a beta blocker. Beta blocker. Whereas phenoxypyrazine is a prototype of an alpha blocker. Alpha blocker. And the only drug that is capable, basically, methylamine blocks the reflex tachycardia, which is induced by the drug X. So the drug X led to fall of blood pressure, and the methylamine blocked the reflex tachycardia. So that means drug X is a beta-2 agonistic agent. Like terbutaline is what you have to basically remember. Alpha-1 agonist. So basically remember, very simple, Dr. Alpha-1, Alpha-2, Beta-1, Beta-2. Simple. Beta-1 कहाँ होता है? हमारा एक दिल होता, दो लंग होता. So remember, beta-1 is there on the heart and it leads to tachycardia. That's what you need to remember. Okay? Beta-2, it is there in the lungs and it leads to bronchodilation. Salbutamol, what is that? Beta-2 agonistic drug. So bronchodilation. Alpha-1 is there on the blood vessels and it leads to vasoconstriction. And alpha-2 is located in the brain and normally it inhibits sympathetic outflow. Sympathetic outflow. So if you stimulate If you give an alpha-2 agonist, give me an example of alpha-2 agonist. Alpha-2 agonist, clonidine is a alpha-2 agonist. If you stimulate alpha-2 agonist, it will further inhibit the sympathetic outflow and that lead to vasodilatation. That is the reason we use clonidine as a antihypertensive. ये simple things आप याद रखना डॉक्टर. So alpha-1 agonist, if you give, what will happen? Alpha-1, alpha-2 में alpha-1 agonist is a vasoconstrictor that lead to intense vasoconstriction, rise of the blood pressure, and that lead to reflex bradycardia. And how can you block that reflex bradycardia? So how increase the pressure, blood pressure will lead to reflex bradycardia. Increased blood pressure will go and tell the vagus. Vagus will tell the heart, Haista, slow down, ho jao. So it will slow down. So if you want to avoid reflex bradycardia, then you need to do something that is vagolytic, prevents vagus from slowing down. That is what is done by the atropine, is what you need to remember. Reflex tachycardia caused by albuterol. How can you block it? Albuterol. Pehla, what is albuterol? You should remember that it is a beta-2 agonist, which is a vasodilator, albuterol. And once vasodilator is acting, the BP is falling, and that lead to a baroreceptor reflex where sympathetic outflow will increase and the heart will go into reflex tachycardia. So how can you prevent this? You have to give something which is a beta blocker, in this, metoprolol. Once more, let me tell you. Albuterol is a beta-2 agonist. It leads to vasodilatation, that leads to fall of BP, that will stimulate sympathetic, that will cause reflex tachycardia, which can be prevented by giving beta blocker, which is metoprolol, is what you need to remember. So the last question for today's wonderful evening, doctor, is there are 4 drugs. Drug 1, 2, 3, 4. Before progestin, after progestin. So based on that, identify what is the drug 1, 2, 3, 4 is the examiner's question. So very simple question you can answer. Only isoproterenol. So you should remember, only isoproterenol can cause a fall of mean blood pressure, and it activates beta receptors and has no effect on alpha receptors. That's the reason even if you give progestin, which is an alpha blocker, it is not going to affect the reflex tachycardia caused by isoproterenol. So that is the reason, if you look of all these drugs, only the drug 3, whether you do progestin or no progestin, whether you do progestin or no progestin, it has no effect on the reflex tachycardia. So that is the reason the drug 3 is considered to be the isoproterenol. Similarly, what is the difference between isoproterenol, epinephrine, norepinephrine? You need to be 100% sure in order to answer this question. So, doctor, with that, we come to the end of today's session. Every day, 30 questions given as a quiz, followed by a discussion. So don't forget to tune yourself 6 p.m. to 7:30 p.m. every day on the YouTube channel. Also invite your friends. Thank you.